Just give it another minute. All right. Well, it's 10:31, and so probably timely to get started. And so I will. So hello and welcome everybody to this second day of the 2021 Emerging Issues in Science and Society Symposium. The symposium is hosted by the Deakin Science and Society Network at Deakin University and supported by the Australian Academy of Sciences National Committee for History and Philosophy of Science. I'm Dr. Timothy Neal, and I'm a DECRA Senior Research Fellow at the Alfred Deakin Institute here at the university, and also the convener of the Deakin Science and Society Network. I'd like to begin this session first by acknowledging the traditional owners of the land on which I'm beaming out to you in this very sunny spot in Naarm, Melbourne, Australia, the Wurundjeri people of the Kulin Nation. And as we gather for this meeting, physically dispersed and virtually constructed, let us take a moment to reflect on the meaning of place. In doing so, recognize the various traditional lands on which we all work and live today. We acknowledge the elders, past, present, and emerging of all the lands and their ancestral spirits with gratitude and respect. So on Tuesday, we were welcomed by the Deputy Vice Chancellor of Research, Professor Julie Owens, and I'd like to reiterate our thanks to Julie for that welcome and to the Office of the Deputy Vice Chancellor for its support. Just quickly, before we get kicked off with the discussion today in session one, I'll just tell you a little bit about the Science and Society Network. So what the Science Society Network is, for those of you who aren't familiar with it, it's an interdisciplinary capability at the university. It's established to support researchers finding new solutions to the problems we face. The network reaches across the disciplinary divides of our university institutions and the divides between research policy and practice. We emphasize the effective communication and translation of research, as the benefits of knowledge can't fully be realized, we believe, unless information is shared and shared widely across different audiences. So in short, as we often say at Network, it supports science literate social research and socially engaged science that makes an impact. And we do that in various ways. For example, we have an annual Incubator grants program, which you can look up on our website. Every year we try and give support to teams of, scholars who may be from science, technology, engineering, and mathematics, or STEM, and on the other side, humanities, arts, and the social sciences, HAS. And so we try through our grants program to bring STEM and HAS scholars together to work on new projects. Another part of the way in which we try to achieve our goals is through our events, like our seminar series and this symposium. This is our third Emerging Issues in Science and Society Symposium. And at each one, we try to do what we're doing today, and what we do at every event is bring together humanities, HAS scholars and STEM scholars who are interested in the same kinds of problems, that we bring them together to try and have a conversation, because we believe that these kinds of conversations are the beginning of new solutions, new collaborations, new knowledge. So this year's symposium features 4 sessions over 2 days. On Tuesday, we had our first sessions were focused on the anthropause. I have to say that slowly because it's a new word, anthropause, which is the global and ongoing reduction in human mobility resulting from the COVID-19 pandemic. And our second session examined the politics of recognition through biometrics, meaning the analysis of people's unique physical and behavioral characteristics, through various kind of tracking and observational technologies. Today, we kick off our third session looking at the link of emerging infection and illness data relating to COVID-19. And the fourth session addresses the reframing and recentering of Indigenous ways of knowing in Western Museum collections. I'll let the chairs of these latter two sessions, Professor Jeff Craig and Professor Emma Cavall, I'll let them do the introductions. But in the meantime, just finish with a note of thanks. First, thanks to the network, its leadership for helping make this event happen. This year virtually, online, which is probably no less intensive than trying to do it in person. So I'd like to thank our deputy conveners, Radhika Guru and Ewan Ritchie, and our 8 theme leaders, Nira Bhatia, Jeff Craig, Radhika, Ewan, Leonard Hoon, Will Smith, Gabriel Fletcher, and Emma Cavall, as well as our great program coordinator, Tal Fan, and our media and communications officer, Giles Campbell-Wright, for making this event possible. And lastly, before I hand over to Jeff and our speakers, a sincere thanks to everyone tuning into this symposium. If you're new to the network and our events, then welcome, and been tuning in for some time, then thank you for your continued interest. Whoever you are, we hope that you find the symposium edifying and interesting, and look forward to welcoming you to future events, whether those are virtual or in person. One last note, reminder, you can follow or contribute on Twitter. Our hashtag is EISS2021, or go to our YouTube, see lots of content there, including these seminars. And so with that, I will pass over to Jeff.
Many thanks, Tim. I'd like to start by acknowledging the traditional custodians of the land that I live on, the Wadawurrung people, and pay respect to their elders, their spiritual and cultural practices. I'd like to specifically highlight their floral symbol. Some of you may have seen it when driving down towards the Surf Coast. It's the yam daisy. It's actually one of 3 different species of the genus Microceres, and it was grown for food. It's a small size of a small multi-rooted carrot, but it was trampled underfoot by the livestock of the early settlers. And I think there's a parallel there for the Aboriginal and Torres Strait Islander people. So I'd like to also extend my welcome to the Deakin Science and Society Network Emerging Issues in Science and Society session on modelling COVID-19. My name's Jeff Craig, and I'm Professor of Epigenetics and Cell Biology at Deakin's School of Medicine, and I'm co-leader of the Healthy Futures theme with Associate Professor Nira Bhatia. I'm joined this morning by our 2 guests, Catherine Bennett from Deakin and John Mathewson from Massey University in New Zealand. The format is a short introduction from me. Then each of the speakers gets to speak for 10 or so minutes to talk about their experience in an interpretation of modelling COVID-19. And there's 30 minutes then for a moderated discussion by me of the panelists, and then about another half hour for the audience questions. But again, feel free to post your questions raise your hand when the time comes, or post your questions in chat. So the theme for these sessions is mathematical models based on the emerging SARS-CoV-2 infection and the illness. How these have been interpreted by social and epidemiological researchers to provide rapid information to inform policy in Victoria and Australia and beyond. We'll discuss how politicians, health services, and the public have responded to this advice and compare in a global context. Now, the theme is unprecedented, which I looked at the definition. It's never known before and never done before. So never known before. The virus is severe acute respiratory syndrome coronavirus 2, shortened to SARS-CoV-2, and the disease was called, and still is called, coronavirus disease, or COVID-19 for short. Never been done before? Well, we haven't really had such a global pandemic. There's already been 148 million cases and 3 million deaths, 1 in 50. Looking at the update today, there was 72,000 cases in Brazil, 320,000 in India, 3,000 deaths in both in India and Brazil. So it's really still raging on. And as you'll hear from our two speakers, the journey from modelling to policy implementation has been also an unprecedented one out of necessity. So the data produced by the modelling is filtered through a diverse set of individuals from multiple disciplines before and after implementation. It's no wonder that mistakes have been made, but we must remember that the successes that have been achieved as well. So I've introduced, I guess I'll introduce each of them more before their presentations. John is going to broadly characterize COVID-19 models, and Catherine will discuss the implementation of specific epidemiological models used in the pandemic. So let's go straight to John, shall we? Welcome, John. John is a philosopher of science, with a background in clinical medicine, based at the Albany campus of Massey University. His research interests include concepts of health and disease and how these connect to more fundamental biological notions such as evolutionary function, scientific modeling, particularly regarding the limitations and trade-offs faced by modelers, and what features of the modeler's objectives and subject domain affect those trade-offs. The delineation of investigation of populations in biology, medicine, and the social scientists. The last of these projects is the subject of a current Marsden Fast Start grant through the Royal Society, Te Aparangi, and I hope I pronounced that correctly, John. So welcome, John. Thank you very much for being part of this, and take it away, please.
Great. Thank you very much for having me here and inviting me to be part of this session. It's very exciting. I'm going to open with some very broad philosophical comments about modelling in science in general, and then I'm going to tie this to some more specific issues regarding modelling of COVID in the last year and a half or so. Modeling's an integral part of science. It's part of everyday science, especially when the scientists are interested in investigating systems. They can't be looked at directly. I think it's safe to say that we've heard more about modelling in the last 17 months or so than ever, certainly in the public domain. And that seems fair enough, because these models have obviously played an absolutely immense role in shaping what our lives have been like. One thing that really interests me about that is that there's a slight problem here in that there's a potential mismatch between what people standardly expect of science and what modelling is about and what models can deliver. So of course, scientific claims have huge amount of authority, and at least the perception often is that this comes from the fact that science deals in facts. So there's very careful vetting of research prior to there being some sort of announcement from the sciences, and usually that's taken to be at least our best shot at representing the world as it actually is. So when the scientists tell us something is the case, then we feel we have good reason to believe it. Now, scientific models don't really follow that pattern, or at least not exactly, because models are extremely abstract, idealized, they leave things out, they simplify, and sometimes they just say things that are outright false about the world. So just as a general series of examples, models can be about populations that grow at constant rates, or consumers who are perfectly informed about the marketplace, or, for example, some models represent populations where all of the individuals in that population have the same risk of catching a particular disease. And these are obviously not true of the real systems that the models are about. So it's accepted I think, pretty much universally amongst modelers that it's just the case that models are all false. And moreover, and really importantly, the people making these models and using them know that they're false. They've designed them to be that way. Well, why is that? Okay. Well, again, it's the case, because models are often used when we can't directly study a system. And there are lots of reasons why that might happen. So, for example, sometimes it's because the system is extremely complex. Sometimes it's that the data is just not available to us for various reasons. For example, it might be that we're thinking about things that haven't happened yet, or certainly have never happened before. And sometimes it's completely unethical for us to obtain that data. And so we need to think about these by thinking about something else rather than the real world, namely a model of that real world. Now, given this means that the models often need to be simplified, so they're not as complex, or we need to make assumptions without the full data available to us because it's not available, or we might use models because we want to test scenarios that just haven't occurred yet. Now, of course, this requires as much good data as we can get, but sometimes that data just isn't available. And now thinking about the case with COVID-19, we can see why models were so important, particularly at the very start of the pandemic, because we met most of those criteria. The spread of a new pathogen across the world, when we're not even sure how it's actually being spread to begin with, is an incredibly complex system to try to come to grips with. The data just wasn't available, or at least a lot of the data wasn't available. We didn't know that much about it, at least to begin with, again. And it's not like we were in a position to do some experiments to find that out. We couldn't test groups of people to see how the disease would spread amongst them, given certain changes that we made. And we also needed to think a lot about a number of different possible scenarios that we might be in or want to generate. So it makes a lot of sense that models played such an important role in the science of COVID-19. So we needed to use simplified models based on a number of assumptions, and we needed to use them in our science, even though we knew that these weren't going to be telling us the exact truth and nothing but the truth. Okay, so that's why they were needed. I just want to say a little bit about, in that case, how models are useful, even though they're not true. Now, there's lots and lots of things to say here, but particularly in the work that I do, one very important idea is that models are useful when they are similar enough in the right ways to the target that they're actually representing for us. So they're useful in very specific ways, depending on the way that they've been designed. And then they'll be useful, even if they're not giving us the exact truth about everything, they can still be useful for us to, for example, base our actions on those as long as they're doing their job correctly. Now, it's one thing to say that models need to be similar to the target that we're interested in, but that's a very slippery kind of idea. So I'm going to say just a little bit more about that. Lots of things can be similar to a system, and so the main thing to think about is what do we need to be similar to, and how will we manage that? So that means that we can have different models built with different goals in mind when we're thinking about one of these complicated systems. And again, there's lots of different ways that we might think about that. For example, some models are useful precisely because they're wrong in particular ways, because they show us that we're missing something important. But in the context of epidemiological modeling, a quite standard kind of contrast to make is between models that are forecasts and models that are projections about scenarios. So just very briefly, some models are intended to generate predictions about the future as it's actually going to be. So a non-COVID example of this might be a weather forecasting model. So there, what we're mostly interested in is accuracy of outputs. So we want to know how the actual world is going to turn out, and so we can base our decisions on that. Modelers who make these kinds of models don't have to care so much about how the model gets there. They don't need to worry about getting the underlying mechanism right. They just need to worry about accuracy in terms of results. And that means, though, in cases where the data is poor, we might have to mitigate our expectations of such models, because the amount of similarity that we can get to an outcome when we don't have the data required to get an exact match at the end means that we need to take some of these results with a grain of salt. Sometimes we might be only able to get things roughly right. Sometimes that's enough to be able to make our decisions, but we have to make sure that we mitigate our expectations. On the other hand, some models are about figuring out how things might turn out under certain circumstances, about projecting a particular kind of scenario. So an example here might be something like deciding what a particular conservation effort might achieve. Now, we might not do it. It might not be that that outcome actually occurs, but making a projection based on that scenario about particular kinds of settings is part of deciding whether we're going to act in that particular way or not. Now, these models do have to get the mechanism pretty right, because in order to be able to understand how something is going to change when you intervene on a particular way, it means that you do need to know or be representing the underlying mechanism. Now, all of that is meant to underline this idea that in order to understand whether a model is doing a good job, you need to know what job it was actually built for, what it was intended to do. So a model that's projecting about a possible scenario outcome that we haven't actually necessarily elected to do hasn't failed just because it doesn't get the actual outcome correct, obviously. And a forecast that ends up wrong because we changed how things are hasn't failed either, okay, because it wasn't built to be able to tell us how the system is going to change when we intervene on it. Okay, so just to summarize that briefly, some of the things that I think are really important to keep in mind here are models don't tell us the truth. They actually misrepresent the world in various ways, and that's done with intent because of the limitations that are often in place when we're having to model. We're doing the best we can with the data we have when we're looking at the particular system that we are. So rather than being true of the system, they're useful by being similar and sometimes dissimilar in particular kinds of ways to achieve a very particular kind of a task. So it's not a problem that models don't get absolutely everything right. The problem arises when a model is used or interpreted in ways for which it wasn't built. When our expectations of the model and what the model is actually able to do don't match up appropriately. And this can happen for lots and lots of different reasons. For example, if the public isn't particularly well informed about the goals of the model, for example, then expectations don't necessarily meet up with outcomes. And the same goes for policymakers as well. When policymakers aren't well aware of what the limitations are, then there might be problems generated by that mismatch. Okay, so now I'm just going to talk a bit more about the particular scenario of COVID. So first, this idea that models can be intended for particular purposes, for example, forecasting or projecting about specific scenarios. Now, this is the case in epidemiology. We can have models that do one or the other of these. And so in the case of COVID, for example, if a model is intended to represent a very specific scenario, for example, a particular level of lockdown at a very particular time when there was this many cases, etc., that shouldn't be interpreted as a prediction about what's actually going to happen. It's about what might or would happen in that particular scenario because we want to probe different options for what we might do. What about the need for reasonable data? Well, obviously, this was pretty bad, especially at the start. And I think Catherine's going to speak to this some more when she's talking. So I'm not going to go into it very far at all. But a lot of assumptions had to be made at the very beginning when these models were being generated. I mean, for example, we didn't even know what the reproduction number was or how that would be affected by distancing, etc. So there was a lot of uncertainty in these models. Another feature that's significant here is that errors here, of course, had very large effects because these kinds of models can be sensitive to data discrepancies, especially at the start, because, for example, they involve exponential growth. So a very small difference at the beginning of the model can have massive effects later on, which of course made it a very difficult task. And then finally, COVID models are about humans who are very hard to make generalizations about. And so the kinds of assumptions and idealizations that we see in modeling in general can be very tricky indeed. And I think one particularly interesting issue here is the fact that humans respond to incoming information. And that includes the models themselves. If you're anything like me, you spent a lot of time looking at exponential curves about 12 months ago. So what that means is that a model that gets communicated to policymakers and the public actually has an effect on its own accuracy, right? And this is certainly the case with COVID. So, for example, if we let people know that COVID is going to spread rampantly, that's going to cause people to act in ways that mean that it doesn't spread as rampantly as it would have, which of course makes for a very strange feedback loop if we're thinking about the accuracy of the models. Okay, and then finally, just talking about not meeting expectations. So this is a bit speculative. I'm not going to say anything too definitive here, but as I said, the real problem is when the expectations about a model don't match the model's defined goals. And that's important, of course, in all sorts of ways, but here are two issues that I think are possible and important. So the first is when the public doesn't quite understand what the model wasn't planned to do. So if the public feels that a model has predicted that something's going to occur and then that thing does not occur, then clearly people are going to wonder why they should be listening to the model. Now, this mismatch can happen for all sorts of reasons, but I think an important consideration is what I started out with, which is that not everyone understands the limitations of modeling and has a particular picture of how science progresses in their minds. And so even in cases, there are very clear cases where the modelers have been very, very careful and explicit to point out the limitations of the models that they have been putting forwards, and yet people did not understand those limits. And another potential problem, and again, I'm not going to say anything definitive here, but another obvious problem is if the decision makers themselves don't understand the roles of the models. So the idea is this, a model based on idealizations and background assumptions and limited data, it's a good model as long as we understand what those limitations are and what the setting is in which it was generated. It's a perfectly good model in that setting, even though it's got quite clear limitations. The problem arises when the model is seen to be more reliable or doing more than what it was actually designed to be able to manage. Now, again, I'm not saying whether or not this has occurred, certainly not in Victoria, but it is another place where significant misunderstanding can certainly occur. And I think I'll leave it there actually and hand over to Catherine.
Thanks, John. That was a most enlightening talk. I learned a lot. I think the one statement I focused on is models affect their own accuracy. I'd never thought about it like that before. Really thanks, a lot of thanks for that. So now I'll introduce Professor Catherine Bennett, who was appointed inaugural chair in epidemiology at Deakin University in 2009. And prior to that was associate professor in epidemiology at the University of Melbourne. Her undergraduate training was in genetics and microbiology and her PhD in biological anthropology. She's obviously very multidisciplinary in herself. Catherine was trained in infectious diseases modeling at the London School of Hygiene and Tropical Medicine. She completed a master's in applied epidemiology with the Australian National University in 2000, and she specialised in communicable disease epidemiology. She worked with Hunter Public Health Unit, New South Wales, and was appointed Olympic Public Health Coordinator for Northern Sydney, overseeing incident risk mitigation and response planning, outbreak investigations, and surveillance. For the last 20 years, she's led research on community transmission of infectious diseases. In the COVID-19 pandemic, Professor Bennett is researching evidence-based policy excess COVID-related deaths, and COVID-safe work practices. She engaged in the analysis of and expert commentary on the pandemic in Australia and globally. So over to you, Catherine.
Thanks, Jeff. Just pull up the screen and hope that works. Okay, you've got me. Look, thank you for the invitation to talk today, and it's been interesting talking with John in the lead-up, but also listening to you now, John, because I think there are some really classic examples of both the strength and power of modelling, as well as some of the misunderstandings about modelling, as modeling's been brought into this public domain in a way that's unprecedented in itself. So this talk, I'll focus on a range of things. It's going to be a flying trip through COVID dynamics, as well as how the modelling was used, some of the key modelling examples, and how that was communicated. And I always start my COVID slides with a reminder of how many days since our last lockdown in the country. We thankfully haven't experienced anything like the rest of the world, particularly India and Brazil at the moment. But at the same time, I think it's a reminder that we're constantly making policy decisions around COVID in this country that do have significant impacts. So modeling's place in that. This is the curve that you'll all be familiar with, the number of cases we saw reported each day for the first wave, largely imported cases, and the second wave, which, as we know, started with hotel security guards being infected at 2 hotel sites that then led to this second wave. But one of the fundamental points I want to get across, because it matters to modelling, is that the cases you see are those that were tested. And so we actually don't really know what happened in the first wave, because we didn't have the test kits to test everybody who wanted to be tested, or even the symptomatic people that wanted to be tested. So what happened was they only tested those who were return travellers, their immediate contacts, or people who were so ill from the community that they were actually hospitalised with pneumonia. So a very small sample. We don't know how many cases were missed. We do know there was community transmission in the first wave, and later serology work, which is based on a few, so it's quite rubbery, got very imprecise estimates, but suggest it could be somewhere much closer to the second wave than we believe, or that we understand from these numbers that were reported. And we might have missed cases in the start, and some work we've done looking at deaths associated with pneumonia, not identified as COVID, show a spike in March and April that suggests we had missed cases very early. So I'll come back to this because this is important, because as John was saying, this is all about the data that you feed into your models, what you can possibly achieve with them. The other thing that's important in modelling is understanding outbreak dynamics. And so, you know, if this is that curve you saw, you kind of have a peak, you bring it under control, or it naturally dies out as there aren't susceptible people in the population. And you'll always get these sort of peaks, you get local clusters like we've seen in New South Wales. But what can happen, and what we didn't understand, because this was an unprecedented pandemic, we had seen MERS and SARS previously, other coronavirus outbreaks that we thought might become pandemics, but nothing had taken off in this way. And this virus does behave differently to flu. And one of the important things that we started to see early on, but it took a while to really understand the dynamics, was this transmission associated with super spreader events, particularly in the workplaces. So once you had sufficient number of cases out in the community, you increase the chances of someone taking it to work while they're infectious, being in a workplace where it can take off, infecting other people, and they in turn take it home. And of course, in Victoria, we saw a number of these workplaces to be severely problematic, not just because of the contribution to spread through distribution centres, meatworks and so on, but obviously our aged care was one of those terrible coincidences of a great opportunity for the virus to transmit from person to person, and also where our most vulnerable people were, so where the virus had the greatest impact. So this is a real problem, because it's every one of these clusters is seeding more virus back into other parts of the community, and it makes it much more difficult to control. And we call this cluster transmission. So everybody in the community doesn't have an equal chance of either spreading the virus or getting the virus, and you need to understand where these avenues of transmission are in your community. So as John said, modelling was really important at the outset, but in fact, that's when we had the least information. The Doherty Institute have very experienced infectious disease modellers who've been doing this work with flu and other infectious diseases for a long time. And they were asked by the Australian government to look at what would be the impacts, particularly on ICU, so our intensive care capacity, depending on different scenarios, from everything from unmitigated outbreak, where you just see an absolute peak, the virus gets into the community, you've got a completely susceptible population, and you see what happens, versus various levels of containment. So some level of quarantine for known cases and isolation, but then adding in community restrictions on, that encourage social distancing and hand hygiene and so on. So the very basics of what you might do to reduce that community transmission. And their work found that, particularly with hospitalisation rates, the more you actually control the spread, unsurprisingly, you actually get a reduction in the proportion of people who are infected and the proportion who need hospitalisation. But importantly, what they're looking at is, again, the capacity in our hospital system. And in fact, it's only when you put these things in place, where you actually were adding in social rules around distancing and so on, that you got to a point where you could guarantee that 100% of serious cases had the ICU access that they needed. So that's really what moved to this flattening of the curve dialogue that happened at the time. And as John said, you know, modelling often is about prediction in a general sense, but it's also can be an intervention in its own right. And it came into the common parlance that we were all about flattening the curve, knowing it was somehow tied to our capacity to give everybody the treatment they would need to have the best outcome they could have. So now we jump forward. The next time where we had very significant use of modelling that again caused a lot of public discussion and was used to inform the public was around the second half of the wave. So we're talking about the time September 6, where we've come down from the wave. People are now saying, well, when can we open up? We had below 100 cases a day. And so at this stage, the government in Victoria then released a roadmap. We'd already been a bit slower than other states coming out of the first wave. We had done that successfully, even though it was only a matter of weeks before we started to ease off. But there was this talk at the time that this second wave was really a result of coming out of the first wave too early from our restrictions. And we now know in history, and some of us knew at the time, that actually wasn't true. What we did was enough. But there was this big discussion, because we'd been through such a big wave by our standards, not wanting to risk all that hard work and all this lockdown that had happened. So modelling was now used for the harder task of actually trying to map the way out. So this time, rather than going to the Doherty Institute, our state government actually went to Thompson and Blakely and team, who had put together, they weren't particularly working in infectious diseases beforehand, but they had built a model to test the government's policy, because they were pro-strict lockdown and had felt for a long time that New Zealand had it right and Australia hadn't, even though, as I said, we're over our first wave and we got rid of the virus. So they had put this model together based on what we call an agent-based model, and that is essentially building a computer program which has a whole lot of, in effect, people in it. And you make assumptions about those people's ability to spread or contract the virus, and you can change some of the parameters in your model to add in particular interventions. And so they did some work where this is the data, the actual data we had at the time, that shows that we had a 14-day average of 116 cases on September 4th, just before this announcement was made. And they'd used this model based largely on the first wave. They fitted the model to the first wave, or calibrated it, to predict what would happen going ahead if we opened up, if we reopened. And so they predicted by September 17, so only 10 days in advance, we'd have 63 cases on average a day, 14-day average. And it would take us till October to get down below that. And that's assuming no change, basically. That's saying where we're currently heading. So this is interesting because the very first check date we had then was September the 17th. And in fact, the number of cases we did have on that day, the 14-day rolling average, was 44, which actually sits down here. So it wasn't even within the confidence limits. So right from that first point, as John said, you know, this isn't an accurate model. It wasn't based on good data. It was fitted to the first wave where we couldn't even see all the cases, but it was sort of suggesting what might happen if we continue where we are. More importantly, it was about how that model was built. And so you hear about parameters in the model, and this is the list, all this off the Victorian government website at the time, but with that model, the information that was put in. And I'll just highlight a couple here. One is that you need to put in an estimate of the average infected person in the model, how many people will they infect? And so the world data that we had at that time suggested that the average infected person would infect somewhere between 2.6 and 2.7 people throughout the course of their infective period, which might be 5 to 10 days. But the key here is average, because as I showed you at the start, this isn't about average. One person can infect many in a super spreader event. And in fact, most people, and they say it's between 80 and maybe even 90%, only infect one other, if anyone at all. So the model's about chance. You've got all these little people in the model, and you're saying, what's the chance you're going to pass it on to someone else? But it's much less predictable when that chance event is rare but significant when it does happen. So it's harder to factor that level of lumpy chancing, if you like. The other one is, this had a bit of conversation at the time, was they thought there was a 25% chance that an infected person would be traced. So they were assuming that most people with infection didn't come forward, even if they had symptoms, and or that the contact tracers weren't finding them. And that's a very low percentage. That's very conservative. And they also assumed that 80% of people who were traced would be traced by day 5 or 6. And shortly after this, there was a lot of controversy about our contact tracing in Victoria, but they were really working on the system. And towards the end of this, we actually were going to not just contacts, but also their contacts within 48 hours, and that was nearly 100% of them. So this is probably conservative at that time, but this is something that changed dramatically over the next months and weeks. So that's another problem, that the world doesn't stand still when you're modelling, when you're making these predictions. So this is the key thing in modelling, is not so much to try and predict an exact case number. The idea is that you compare different scenarios usually when it comes to decision making. So you don't necessarily know, that one particular strategy is going to be to give you an exact case number in 2 months' time, but you know that it's going to lead to a worse scenario. So using that model with limitations of the model, they decided that we would actually aim for 5 cases per fortnight. And what this graph shows us is the sort of scenarios under that model. So you run a model 1,000 times and you see how many times, so what's the average number of cases at any time point. So one model would just flatline and say you've got over it. The next model might say, whoa, it takes off, and then you average it. So what they found was that you only had a very low chance of, less than 5%, that if you only opened up with 5 cases, that it would take off. And so this idea that, you would actually prevent takeoff, sure, the less cases you have at the time you open up, that makes sense. But it tells us there's not a lot of difference between 5 and 10 cases. So a lot of the conversation then was, okay, 25, too many, we can't trust that, we don't want to blow what we've already done. 5 or 10, not so different. And surely our systems are improving, and we wouldn't just let it run if it started to take off. It'd become even more aggressive. So that's actually where the public debate was. It was actually about risk tolerance, nothing to do with modelling. But also this idea that they were predicting quite precise numbers and percentages was a bit misleading. But the other thing was the chance that they were talking about was re-entering the second step. And what we were saying is, when are we going to get out of stage 4 modelling? And we're not talking about opening up completely, but this is what this model was saying. What if we open up completely tomorrow? Then we'd have to go back to the second step. And we're saying, well, we just want to get to the second step. We haven't even got there yet. So surely, if that's about going back to the second step, we could have gone to the second step at that point, because the second step's good, according to this model. So it was very strange. And we really didn't understand what was modelled until Tony Blakely himself put an op-ed together in the Age the following weekend and talked about it was something like stage 3 going to something like stage 2. We were in stage 4. We wanted to go to step 2 on the model, on the roadmap model. And so the modelling actually didn't relate to the question. And it really looked like it was being used to justify this quite strict model or roadmap out, where we went not just by achievements in terms of trying to get down to this magic less than 5 cases on a 14-day rolling average, but also we had these dates. And even if you got there, like we eventually did, you might get there on the 18th of September, but we had to wait to the 28th to open up, even if we'd met the requirements. So there wasn't a clear link between even the modelling and how that was interpreted and how it related to these models. On top of that, there were some changes as we move through these steps, even by date rather than by achievement. The curfew was removed. That was very controversial. But a 5-kilometre rule was brought in that wasn't a part of the roadmap initially, even though everyone agreed it was a very conservative roadmap. And then that was continued into the next step. And in fact, 20-kilometre rule went well beyond that as well. So this is, modelling was done a couple of weeks into that roadmap to see when we were ready for the second step. Burnett Institute had been working on modelling COVID from the start. They had a COVISM program they were setting up, which was a more nuanced program. They were trying to factor in, people going out to cafes and doing other things. But they also found that, if we opened up with the number of cases that we were seeing at the time, like New South Wales or Victoria, things would take off in a way that was unacceptable. So if we had 50 cases and opened up, there was too high a chance that we would see another resurgence. But what they also found was if we got to 10 cases a day, which is actually pretty close to where we were at the time, you only had a 17% chance of having a resurgence, assuming you opened up fully. And again, we weren't talking about opening up fully. And so that was actually a good result, but it was never presented that way. It was always presented as if we do anything but what we're doing now, this will take off. And so they were not clear about what actual levels of restriction were in the models when they communicated them. And finally, this is, I think, a really good example of how modelling can be used. You had 2 different scenarios related to going back to school, and the Murdoch Institute were asked to look at this. It was a very slow opening of schools, particularly primary schools, under the roadmap. And they looked at 2 scenarios, one where they followed the roadmap and another where they brought forward the opening of primary schools, and could see that the chance of re-entering, again, a second step, were not that different between the 2 scenarios. So without even wondering what they are, it's looking at the gap really and saying, well, that suggests we're not adding a lot of risk by doing this, and it makes a big difference to families and to childhood education. So they went with that. But to my mind, that was one of the few examples of where it was done. It was done clearly, it directly informed policy, and it was based on a relative risk assessment. One of the other things, just to briefly touch on here, as I start to wrap up, is this is a really nice piece of work that the ABC did, breaking down the second wave into clustered cases according to where the cases acquired the infection. And so this is colour-coded, and blue suggests we have a massive problem, and we know aged care was an area where we had most cases. And by the second half of the second wave, 2/3 of cases were either people who worked in healthcare or their direct family contacts, and most of that was aged care. And you can see that other clusters, explain very little. What's important here is this changes over time. We had some aged care that actually had a persistent outbreak that lasted over 3 months, which is quite extraordinary. But we had an expansion of the number of cases, even though this had been running for a couple of months, towards the end where we saw more aged care facilities involved. This is the time the modelling was done, in the lead up to this roadmap announcement. And you can see that this is different to this, very different to the first wave, and completely different to what happened afterwards. So all those dynamics we've talked about now shift, and the importance of lockdown in the community shifts. And you've got these outbreaks in aged care receding outbreaks in the community, but they are contained, particularly by October, with this contact of contacts, very aggressive follow-up that is completely beyond anything in the model. And so I would argue potentially we could have come out of lockdown 6 to 8 weeks earlier and had the same outcome. And that's the issue, that the world changes around you, but you're making assumptions based on the past and about the relative good. So as I said, the first point missed out where we got to. The second point was actually reasonably close, where we crossed over this magic line of 5 cases. And the modellers themselves use that to say, well, see, our model was accurate. So you ignore this one when you're outside, and here you say, well, pretty close actually to where you came out. But the point was, it was really about this roadmap and the fact that, yes, we did track, we did open up on the 28th at the second step, but we'd actually hit the targets on the 16th. We did open up to the final step on the 22nd of the 11th, but in fact, we'd hit those targets by the 13th of the 9th. So again, we had another 10-day wait because suddenly we had everything from the modelling, even conservative modelling, overridden by other policy decisions. And ultimately, for me, it was the fact we were in stage 4 right throughout this period, when in fact we were not modelling stage 4 at all. It was all about 2 or 3. So less about this point where we went from stage 3 to stage 4, we brought in masks and so on, more about this end point where our lockdown persisted well beyond what anyone would consider a significant wave, and including our restrictions on movement, 20-kilometre rule, ring of steel and so on, that actually went beyond that. So from 112 days of lockdown, we went even further with these very strict rules. And as I said, the world, if you were looking at this, you'd actually be thinking about the pandemic and our particular second wave quite differently. So I'll stop there.
Many thanks, Catherine, for that. It was a great dissection of our responses versus the models. And I don't know about the others in the audience, but I kind of could imagine myself in each situation. At each time, it was like time travel. What were we like at the time? What were we feeling at the time? And it's a unique way to go back and dissect all those responses and how it ultimately affected the rest of us. So we're getting some great feedback, incredible presentation, for example. So on to questions now, and I think I have many of my own, but why not go to one from the audience? So Radhika, would you like to ask your question?
Thank you, Jeff, and thank you to both John and Catherine for these brilliant presentations. It's absolutely fascinating for me as a sociologist of science, listening to the behind the curtains work on it, and also John, your wonderful analysis of what modeling does, what it is as an epistemic practice, and what it is designed to do, and what happens when models fail, and why it's actually some are designed to fail, etc. I was just thinking that Catherine, you mentioned flattening the curve and things like that becoming part of our common vocabulary, at this time, and the very public view of science in the making, and this whole business of, is the vaccine being rushed? Is there how the testing is done, and how more information comes in that might negate a previous theory, etc., etc. And I was wondering whether all this, on the one hand, it should actually increase trust in science because you can actually see the process, but it seems as though it might actually be eroding trust in science. And I wonder whether you agree with that. And I don't know what the statistics are for anti-vaxxing for anti-vaxxers, whether that has increased now, or whether that has, but even beyond just vaccinations, just the idea of, because we're living in this kind of shaky era of, conspiracy theories and so on, whether this has been an unfortunate, event in history.
Yeah, look, really good points, Radhika. I think we struggled with this all the way through. There was a big, one of the problems with an unprecedented outbreak in a pandemic, and when there is unknown, is that it's a breeding ground for conspiracy theories, because there is fear in the community and people are hungry for information, and people rapidly fill that gap, and people were very keen to blame very early on, and we saw how that played out across continents. So that was a very dynamic communication environment to be working in initially. Our communication was very coordinated early on in Australia between states and also between state and federal government. And there has to be, there's sort of basic rules of risk communication in those settings, which are, tell them what you know, tell them what you don't know, tell them what, you're doing and what they need to do as a community. And so some of that was coming through, but it wasn't coming through very convincingly, and it didn't build confidence even in the process of learning more about this, and the fact that we knew actually those basics around hygiene. We're taught as epidemiologists, that's the first thing you do. If you don't know what's going on, tell everyone to distance and practice hygiene, because if it's an infectious disease, it can never do any harm, and it might do good, and in fact it usually does. So there are things you could do with confidence, but it didn't really come through that way. I think Victoria actually did quite well in the first wave. When Australia went quite early and quite hard with its restrictions, and Victoria did that and took a bit of a lead role in that, I was quite optimistic. But things start to change when you try and sustain something for a long period of time, and if you have politics actually as a filter between the health department and the public, as well as actually changing the conversation out in the community, it really gets difficult. And I think by the middle of the second wave, we'd already gone through a lot of divisive conversation around, whether it was elimination or not, and we should be eliminating, and New Zealand did it right, and all those things that were actually, there was a lot of opinion out there that wasn't backed by science at the time. And the media like that, they like hearing the different stories, but I think it does send a confusing message to the public. And so you don't want to be picking on other scientists in the public domain, but also you're just trying to kind of bring it back to say, well, you can have your opinion, but this is what we know, and this is what matters, and this is what's going to happen going ahead in a broad sense, without saying, like some observers were, we're going to have, 57 cases this week. Oh no, we're going to have 72 cases this week now. That's terrible. It was just ridiculous, this kind of doomsayer weirdness about specific numbers off what are profoundly flawed, models when it comes to that kind of specific prediction. Vaccine hesitancy is a major thing. If it was vaccine anti-vaxxers, it'd be easy to deal with because it's a hardcore group and sometimes they bring others on board. What we're talking about is a much greater proportion of the general population that are in this hesitant place. And I think it has increased because we've had changing information about side effects, no matter how rare, that plays on people, particularly if we're not confronted with the day-to-day fear of COVID. We saw the same thing with masks, where information changed and we thought, actually, there's good information that masks probably don't work in the way we think, as a surgical screen to stop the virus coming through or going out. But there seems to be something else about people going out less often if they have to wear masks. And if they do go out wearing a mask, they're more aware, they're more likely to hand hygiene and other things possibly come into play. So we don't exactly know why they work, but we know they work. And there's another important use of modelling, and Burnett have done some work on this, where they've tried to not predict what's going ahead, but unpack what happened in the past. And they've seen how important that rollout of masks was, not just in Melbourne, but across the state. So I do think, there's things that people are still interested in the science, but I had a lot of people come to me basically saying, we trust you, you're on an even keel, we believe you, you're saying these things. But others would just be out there in the media saying, well, we can't believe scientists anymore because they don't agree. So I think you have to think about that in public health messaging more than was done. And I actually respected media's role in trying to counter some of possibly the damage they were causing themselves in other parts of the media, but where someone will come on board and say, we just need someone to talk calmly about this issue. We need someone that people can put questions to, and they pull you in trying to get more balance. But I think a whole series of different things happened all the way through, but right from the start, this has been political, and that makes it really difficult.
Thanks, Catherine. Ewan, do you want to comment on communication in the media?
Just quickly, I mean, I think Catherine's just covered it really nicely, that the messaging is just so crucial. You know, I think the clotting issue, obviously recently, and the withdrawal of AstraZeneca for younger people, you know, in terms of risk, I think, you know, society generally has a really poor grasp of what risk actually is. You know, we obviously jump in cars and happily do so most of the time, and there's obviously a much higher risk with doing that on a day-to-day basis than this vaccine. So there's been opportunities, I think, along the whole way to really get the messaging right. And, you know, Catherine's done a great job personally, but there's been, you know, other cases where I think the messaging has just been a little bit less than what we'd hope for. And, you know, that I guess really touches on, you know, Radhika's point as well, is that, you know, we really need to convey to people what science actually involves as a process and all its uncertainties, but the power of that. And you know, that, you know, we can communicate these things in a better way. But I think Catherine's done a pretty good job of summarising that. But yeah, it's a source of frustration for many of us, whether it's to do with the COVID situation or a whole range of other issues. It apply as well in science. So,
so in a way, as scientists, we have to admit that we know a lot, but we also don't know a lot as well. There's that uncertainty. I think we want people to trust us, but we want people to know that we don't know everything.
Yeah,
so it's a hard balance to make, isn't it?
Yeah. And the importance of trade-offs and making decisions, even with imperfect information.
Okay, thanks, Ewan. A question for John. What really fascinates me is, oh, sorry, go ahead.
Can I just speak to that just briefly?
No problem.
I just wanted, I think that there's sort of also a really like big picture issue here that I think both Catherine and Ewan have touched on, which is again, just people understanding how science actually goes about progressing or goes about its business. And so, I mean, one ironic thing I think is that people see retractions or changes in what the science is saying as a bad thing. But of course it's not. That's one of the best things about science, is that it retracts and changes its opinions according to the information that comes in. And I mean, of course, I'm not going to make any comments about how things were communicated in the last sort of 18 months or so, because it was just unbelievably rapidly changing situation. But it seems that a better understanding by people about the fact that these situations are uncertain, and the way that progress is made is by actually embracing the idea that these things need to be revised, etc., could be extremely useful, sort of as a more general approach to thinking about how this might be communicated to the public.
Thanks, John. Tim, you had a question?
Yes, I mean, it kind of follows on from what we've just been talking about, and something that John said in his presentation about models, you know, affecting their own reception. I do research in relationship to land and fire management, and there's a lot of modeling in that space and prediction of what fires are going to do, for example. And there's something that a lot of fire practitioners talk about is, you know, using the fattest, blurriest crayons in order to kind of, you know, ensure that models are received in the right way, that they're you know, that they affect response. So I'm kind of curious from both your perspectives, John and Catherine, whether or not you have any thoughts on like good examples or good kind of philosophies that modelers should be taking into, you know, how they affect with the, you know, AFFECT, how they affect their reception or their accuracy.
I might go first, and then John, you can kind of expand out from what I say, because I'm going to talk specifically. But I think like all science, you have to be honestly open-minded when you're going into a modelling exercise. I think if you have a strong belief or opinion or stance, it's risky, because there is a process where you're building a model or adapting a model where there is a risk that if you're not as objective as you think you are, that you are going to shape the model to serve your purpose. I thought it was interesting that the model, and I don't know the story behind how it was actually formed, but I do think there was this sort of sense from the group who did the University of Melbourne modelling, Thompson and Blakely, that there was this real, well, we should have done the New Zealand thing, and that the whole conversation around elimination was very strong. And this ties to a question I saw from Carolyn as well. Why would the state government with the Doherty Institute down the road actually go past the Doherty Institute to a team of modellers who put a model together that refuted government policy? Now, you might argue maybe that was a good thing. They were going to the, contrarians to try and, get their view, because then it couldn't be tainted by government. But in fact, you've got a group who work objectively and independently in their modelling that you could have gone to. So it was a very interesting choice that they did that. But I think there's a lot of other things that come into play, and just doing really, quick associations, I can say that there is a positive association between lockdown and government culpability. And we've seen that in the circuit breakers. So in Victoria, we had a couple of incidents where we did have crossover from New South Wales cases in Victoria, with the outbreak associated with the Black Rock Cafe, for example. We didn't go into lockdown. We managed it very aggressively. We did it. We had another case where we had a hotel quarantine worker who was infected and had been out in the community. We didn't go into lockdown. Had the Holiday Inn, where there was a problem because someone had actually apparently declared a nebulizer which shouldn't have been used, and suddenly the government's again responsible for an outbreak, and we have a very different response. So there's all these other things that are driving it. The fact that you can't afford an outbreak to take off, the fact that people are watching you closely, the fact that you want them to be concentrated on containing this rather than what went wrong. But the public actually want to know what went wrong and how we can actually fix that. So I think all of these things together just mean you shouldn't be using modelling for a purpose. You shouldn't use modelling to show how bad things are unless you believe us and you do exactly what we're doing. So there's this whole dynamic around saving Victoria from something that, in fact, the government had, been on watch when it had actually taken off and had missed some critical things, and then went on to deny problems in health response. We're not going to get it right the first time, particularly in an unprecedented outbreak. But to actually try and cover that up and use smoke and mirrors, to me, is where the problem is. Not that we had problems, not that we needed to rebuild our health response, not that there was all this work to do, but it was how that was communicated. And right through to that most recent nebulizer one, where there's clever messaging that actually just highlights that it's clever messaging. It doesn't actually get away from the problem that we had an outbreak we shouldn't have had. And I just think, we've got to move on from that, and we have to go back and unpack the data and understand really what went on, because I just worry that we get caught up in this divisiveness that still persists. There's people that say the government's right. They had to do this lockdown. We had to have that long a lockdown so that we didn't go backwards. But, to get to 0 cases, yes, that's a success. But as I always say, to take 112 days of lockdown to get there shows you that there's a lot wrong. You're rebuilding your health system. You're not containing outbreaks in workplaces. All those conversations we tried to have in the media just to help people understand why the fact they've been good for so long didn't mean that it wasn't important to stay good, but equally they had to understand that we had to get these other things sorted out before we'd see an end to this. So trying to just step back and say, let's get objective models in to answer this specific question, or to look at these relative scenarios and say which way we go. Can we tolerate that extra risk or not? I don't think that's how it was done for the majority of our Wave 2 roadmap, but then it was for specific things like the schools. So at least we have some good examples.
Is it okay if I see that there's lots of questions, so I don't want to...
let's try to keep answers short, and we'll get through the rest. We've got, I think, 5 or 6 really interesting questions as well. So we've got another 20 minutes left. So
okay,
there's time.
So, just talking about the sort of this feedback loop that can develop, and just also managing expectations. I've been thinking a lot about the first model predictions that were sort of used that had some very, very scary numbers that prompted decisions by policymakers. So I'm thinking of the Imperial College model that predicted 500 million deaths, I think it was, in the UK, and in New Zealand we had a model from TPM that predicted 80,000 deaths. Now, at least in the New Zealand case, I can't speak to the Imperial College case. It was extremely explicitly stated by the group that was doing the modelling that this was a worst case scenario. This was a if we did absolutely nothing at all, and intensive care units got overwhelmed, and New Zealand was a special case there because we were at special risk for that. And so this was doing nothing at all. This would be what we would be looking at. And that prompted New Zealand to act in particular ways. And of course, we ended up with 26 deaths instead. One interesting thing, I was looking back at some of the media releases at the time, and actually the modelers said, and by the way, if we instituted everything that we can to try and reduce this, we would be looking at deaths in the order of about 20. So that was interesting. But nevertheless, it was made totally explicit. But there was some backlash in the public following that when we had 26 people die, which of course was extremely tragic, but nothing like in the tens of thousands, in spite of the fact that it was made very explicit that this was just a prediction about the worst case scenario. And so there was this real disconnect between even communicating it very clearly by the modelers and how at least some parts of the public were able to pick up on this. But another thing is, I was thinking about, there are lots of good reasons why you might have a worst case scenario. I'm very interested to know what Catherine has to say about this. So it's useful, for example, to have a baseline at the start of what we might be working on. But also I was thinking about this feedback. Now, it's one thing to say, here's the worst case scenario, thinking that might motivate people to act. If you were to say, here's the best case scenario, that might motivate people to be less concerned. And so it makes total sense to me, as not a professional health professional, that's the way you would go. But it's an interesting decision to make, because you wouldn't want people to become complacent because you presented with them with a best case scenario. Just thinking about the way that news would affect people's behaviour. And just very briefly, sorry, I know that we say that it's very useful to be very transparent about limitations, but I also thought about that in the setting that we were in. So if we were to say, we predict that there will be ICUs will be overwhelmed, but note that our models are extremely limited in lots and lots of ways, and we're really uncertain about that. Again, that's not going to be nearly as effective in producing a particular kind of behaviour. And I'm very curious. I don't know what the right way to think about that is, but I'm extremely curious about that dilemma that must have been that people must have been going through at that time.
And if I can just pick up on some of your questions within that, John, I think it's right. It's hard to, again, the messaging was unprecedented, and we had global connections. We were taking data in and information in right across the world in ways we haven't done before, with this level of health issue. But I do think it's interesting because the idea of having a worst case scenario, I think early on that was setting in limits and saying, well, we have to do something. Now we're deciding what we have to do. And so in Australia, at least, we had these sort of graded scenarios, and it gave us the worst case scenario we'd never do, unmitigated pandemic. But the middle one we could do, but that still wasn't good. We couldn't get everyone into ICU. And the strict one, was something that got everyone into ICU. So that's what we aim for. And I think doing that helps remind people that can't get complacent, because there's this ceiling when it just goes really bad. And so you're kind of aware, and you're giving people the options, and you're saying, this is where we're going to sit, our policy. This is where our public health rules will be formed. So so there's that. But I think later, when you're talking about coming out of a wave, to present worst case scenarios that are actually irrelevant to me was actually fear mongering, and it was keeping people agreeing with lockdown, when in fact the real question about policy is what are the, even with this conservative roadmap, what are the next safe steps and when can we take it? We weren't asking those questions at all. They were just talking it up. And the flip side of that was our politicians, and we have in Victoria an ex-health minister who's a really smart guy and knows a lot about health, and became, took over a lot of the communication and talked a lot of the epi, as he went through. And when it came to modelling, and I don't know how much was just his interpretation of what he was presented with or what he was presented with, but he would talk about, thousands of variables when he was talking about the simulations that were run. He didn't actually understand the basics of modelling. And he introduced this first model to launch the roadmap, this kind of worst case simple model scenario with no data presented. They didn't even tell us in that presentation what they'd modelled. And he talked about that as being a world first example of modelling with thousands of variables. And that was just ludicrous. Anyone who knew anything about modelling, and there's a lot of people, not just in health, who know about modelling, it just made the whole thing more farcical in a way. And so there was this whole problem with both the understanding of what the model is and what it can deliver, but also how that was communicated, that I think undermined whatever value there might have been in that. But it also raised serious questions then about the motivation for using that particular model and those modellers. So I'm not as critical of the model or the modellers as I am perhaps of its application in policy and what was going on there to make them take this model. That we launched the roadmap on the Sunday. The same weekend, the Medical Journal of Australia put out the last model exercise that group did using the same model, which castigated the government for not going into stage 4 lockdown sooner and attributed a whole lot of lives lost to the government. And the same weekend, they're using that same model to justify staying in lockdown. So it's something very strange going on there.
Thanks, Catherine. I think we've had 2 or 3 questions about how about politics. So I guess one from John and one from Carolyn. And I think the crux of this is how does politics influence what is being modelled and what's included in the model? You've touched on this. You've touched on this a little bit. Can you or John expand on that? Are people pushing political agendas over the top of models?
I don't think politics influenced the models apart from what stance particular modellers might have had in the Thomson-Blakely one, but in terms of our state or national politics, they were reliant on the modellers. They asked them to do a task, but they did look to try and update the parameters. And from what I've heard directly and indirectly via the media, is that even Thomson and Blakely's group weren't given access to the data. They couldn't actually pull that together and come up with their own best estimates of some of the parameters. I saw there was a question in there about all those human factors like compliance. There was some data out. They were doing surveys on compliance. Burnett's been doing some work. They were monitoring things like movement using mobile phones at government level. Government had surveys going out regularly about mask use and so on. So they did have some data coming in, but some of it was people in the health department saying, yeah, that sounds about right. Or we're using data out of China to estimate reproductive numbers and things early on. So that they would have tried to pull the best data together. But what I understand from that modelling that was used for the roadmap, the first model, was they were asked to do a couple of scenarios. And it was the Premier himself then who said, what happens if you've got 2, 5, 20, 50 cases and run your model using that at that opening point? And so they ran the model and they gave that to government. And then government looked at that and, they come down. We probably don't have to get down to 2, but we do have to get down to 5, tick. We can tolerate that. We have a very, risk-averse government, particularly, as I said, when they're concerned about shutting this down. We've had so much intervention already and restriction and, economic and health impacts that we need to get this right. You're going to be more conservative anyway. that at the end of the day, that was the limit, I think, of the government actually influencing the model itself, was to set those sort of opening up goals that they could compare between. But then we weren't presented with that. We were just presented with the worst case scenario and told 5 was the number we'd go for.
Thanks, Catherine. There's an important question come up from Rashidul, who said, most of the reported cases regarding COVID positive cases around the world, that's outside Australia, are not the actual case numbers. To me, it sounds scary. We've heard that in Brazil, we've heard that in India, and it must go for other countries. So how can we make an acceptable projection on COVID surveillance for everyone, not just in Australia? Who would like to answer that?
Well, I'll do the epi answer. For surveillance, we often don't get all cases. And in this situation, we know that in different settings and at different time points, your case capture is going to be variable. So it depends on the test kits available, it depends on which parts of the population are affected, depends if being a case is going to take someone out of work they can't afford, and so they don't come forward. There's a whole lot of reasons people haven't been tested, and there might be some missed even through the testing process, particularly in countries that might not have had the best facilities to do the testing. So what we do is, if you're modelling, you're actually saying, well, we're going to see what's the case now, and then we'll see what the case pattern is going to be like of the known cases. And if you assume that that's perhaps the tip of an iceberg, then you're still going to have 50% more cases. Even if you currently don't know how many cases you have, it's going to be that much worse. The only thing that changes is if you see more serious cases, and so more of the cases are captured because they now have to seek medical treatment or other things. So it's one of the challenges. It was pretty good in Australia, I think. I don't think we had many false positives, but one of the big criticisms around this, the naysayers was, but we get false positives, the testing's ridiculous, they run too many cycles to find the viral genetic material, therefore, it's probably wrong. But in fact, we can test 30 or 40,000 people and have 0 cases or 1 case. So it means we don't have a big problem with that. But the reverse of missed cases, if it's consistent, you can still use it because you're not seeing them all, but you're seeing enough to track what the trends are, and particularly at the hospitalisation end, that's what people look at more closely, and that's why we've also looked at deaths, because that's a harder endpoint that they may not be all attributed to COVID, but you can look at what happens compared to previous averages.
Can I just follow up with a really, really quick question? It seems that problems with patchiness of testing, but also part of what you were talking about, Catherine, where you can have actually an R0 very low for most people, but the average R0 is quite high because of so-called super spreader events, etc. I'm just wondering, is this more of a problem when the case load is low, like it is in New Zealand and Australia, rather than in where it's much more widespread? I mean, one single event could make a huge difference, or one series of missed cases would make a huge change if you've got a low caseload, whereas otherwise you could probably sort of take that on the nose and just extrapolate.
That's true, because it is such a chance event. If you've only got 5 cases in the community in a day, but one of them happens to be a super spreader, yes, that can change things dramatically. And we watch the case numbers too closely, and in Australia we were fixated, particularly in Victoria, on mystery cases where they couldn't be linked, but in fact 12% of our mystery cases subsequently were linked back. They just didn't have the data entered in a way that allowed them to make those connections. So this whole thing about the numbers and scrutinising them or over-scrutinising them was actually what I spent most of my time doing, was sitting back and telling the story that I could see through the numbers, what was happening behind the numbers, not necessarily focusing on, oh my God, we've gone up 100% today because we've gone from 1 to 2 cases. So, but I think globally it is a challenge, and it is something that we have to bear in mind. And they have gone back and looked at serology when they had a lull between waves in different countries, whether it was Sweden or the UK. And sometimes we're surprised at how high, the antibody presence is, and suggests that there were more cases than we had any idea about, more asymptomatic cases who are often missed and not tested in many settings. but other times it's lower than you think. So it's impossible to figure it all out. And we have to remember that every time we're looking at graphs, every time we're looking at whatever, it's not only not going to be complete, it's going to be biased, and we don't always understand the way it's biased. But at a global level, particularly when you've got massive numbers, then absolutely tracking what's happening over time, it's all we have. And if it's tracking up, you know you've got a problem. And we could see it coming in India. And then we had a major religious event as they were starting to ease restrictions still with high case numbers. And now we're seeing the devastating but predictable impact on healthcare, which will only inflame the problem in terms of getting the help to the people that need it.
Thanks, Catherine. Something that that John raises, John Noviana, is about how do you account this? What this also fascinates me. How do you account for human values such as compliance with lockdown measures, preferences, for example, willingness to go for a full and hard lockdown, or endorsement of snap interstate borders? And now, of course, here we've got coming out of COVID, we've got compliance with being vaccinated. Some of these, it seems to me that some of these are known. We know about anti-vaxxers, but we may not know what proportion they are. But some of these are unprecedented issues. Can either of you comment on these human factors that may or may not have been taken into account?
Well, as I said, they're actually collecting data actively on that, particularly with the vaccination, and they were doing this well and truly in the lead up as well. So that's something that's really important to get accurate information, not just on the proportions, but also on the different sectors of our community where there's the greatest hesitancy, and trying to understand what their questions are, what information they need to address any concerns they have that might not be founded in fact, that might be, you know, coming in from other information sources. So for all factors, including compliance through the lockdown, there was some attempt, not always a great, data set, but the best we had. And I think it was really useful that some groups like the Burnett were doing some work in parallel, doing quite detailed qualitative and quantitative work to talk to people about lockdown, their responses, getting a feel for not only compliance, but what was motivating people to comply or why they might not be complying. So I think, there was some rich data collected because, but equally, as John said, you can't put all of that in models. And these models don't even take into account effectively cluster transmission. And so you can't put in all the situations that might occur just at the right time or just at the wrong time in terms of compliance as well. And if you did put all that in, it'd be running in real time, and it's not giving you any advance sort of notice about where you might go with this.
Thanks, Catherine. John, do you want to make a very final last quick comment?
No, I'm good. Thank you, though.
Okay. Well, yeah. So it's about 1.5 minutes to 12. So I think we don't have time for any more questions. But I'd like to first thank both panelists, John Mathewson and Catherine Bennett, for their excellent exploration of the different and complementary aspects of COVID-19 modelling, and for all the questions and comments that we got from the audience. It's been very enlightening for me. And of course, this discussion could go on for many more hours. But I think it's really made us all think. There's a few papers that have been posted, a few references been posted, and I'm sure that we can post these to all attendees after the end of this meeting. I'm certainly really want to have a look to see what's out there. So I thank you again for all your attention, and have a safe rest of the day. And also don't forget that we have session 4 coming up this afternoon, reframing biocultural collection. So I hope to see you all there. Thanks very much.
Thank you.